Our next speaker is moving on to our final big theme of the day, which is about non-communicable diseases. We've heard so much about it and how it's really taken over the world, not just the rich world. And to talk to us about it and give us our keynote, we have from the University of Auckland, Professor Robert Beaglehole. And to introduce the theme, we have authors of 3 different papers published yesterday on their research around the phenomenal growth of NCDs.
Dementia is a major problem in developing countries, but estimates vary widely, partly because of the tools that are used. In northern Tanzania, in an elderly population, we used the 1066 criteria, which has been specifically developed for developing countries, and compared this to the gold standard of the DSM-4 criteria, and found that the 1066 criteria gave an estimate of 3 times that of the DSM-4 criteria.
5SPICE is a new community health worker framework. It's an acronym for 5 essential elements that combine to make a project successful in its unique context. That's supervision, partners, incentives, choice, and education. Our paper represents the first application of the framework as a quality improvement thought exercise and hypothesis builder. We envision this model as being exploratory, not prescriptive. We hope that the universality, if not humorous nature of the cooking metaphor implicit to the name opens the door for many voices to participate in the conversations that it starts.
My paper presents critical realism as an innovative system for research in tobacco control and prevention in different resource settings. Any program or intervention that is transposed from one country to the other or from one setting to the other is complex. In critical realism's terms, researchers need to consider what works for whom and in what context.
Thank you. Good afternoon. You've heard a lot about non-communicable diseases, and there are some things I'm going to emphasize this afternoon. And the reason why this is such an important issue for all of us, not just those of us in this room in this sort of country, but globally, these are the conditions from which we are all going to die. The advantage that we have in Sweden, in New Zealand, where I'm from, is that we're going to die from these conditions at an old age. The real problem, the challenge now facing those of us interested in the prevention of these conditions is that they're killing, excuse me, I'll keep my distance. They're killing people in low and middle income countries at a much higher rate now than in Sweden, and people in low and middle income countries are dying at a younger age from these conditions than in this country. There are a couple of things I want to do. I want to talk about the crisis and how we overcome the neglect of this very important cause of death and disability. There's a global context, some of which we've heard about. We've heard a lot about plans and strategies. We need now to do what we know works. We need to implement policy. I want to talk about accountability again, briefly, building on the experience that Richard and others have had in women's and children's health. And finally, talk about how NCDs are central to health and will, we hope, be central to the post-2015 development agenda. These are the facts, some of which you've heard. We're talking about heart disease. We're talking about stroke. We're talking about cancer, diabetes, chronic respiratory diseases. 66% of all deaths globally, 2/3 of all deaths are due to these conditions. That is, of the 53 million deaths every year, 35 million deaths will be from these 4 conditions. And 80% of these deaths are now in low and middle income countries. About half of all premature deaths from NCDs are preventable. My definition of premature is increasing every year. Currently, I view a premature NCD death as one that occurs under the age of 70. And about half of the NCD deaths globally occur in these relatively young ages. Half are in women. This is just not a white middle-class men's problem. Half of the NCD deaths around the world occur in women. Most of the women in this audience will die from an NCD. The good news is that premature deaths from NCDs are largely avoidable. And we have had tremendous success in reducing death rates from NCDs in this country, New Zealand, the United Kingdom. That's why the death rates in these countries are now much lower than in China, Nigeria, etc. There is a very close bidirectional relationship with poverty. These conditions are caused by poverty, and these conditions are caused by poverty, and NCDs can impoverish families if there is no safety net, no publicly funded health systems. The leading risk factors globally, as we know from the Global Burden of Disease study, are high blood pressure, as we've heard before, tobacco use, and alcohol use. The leading global causes of death are NCDs. The risk factors are already well known, and we know what to do. We heard, I think, this morning about the UN high-level meeting, the second time the United Nations General Assembly has discussed a health issue, September 2011, a turning point for NCDs. Many commitments were made, some of them are listed here, and as we've heard from Richard, these commitments, these promises, are easy to make, and heads of state signed up to 68 paragraphs worth of commitments. They're much more difficult to implement, and of course, more difficult to monitor, and I'll come back to that. WHO is masterful at drawing up plans, strategies, action plans, and we have wonderful action plans on NCDs currently being revised by member states. We have a global monitoring framework which talks about goals and targets, and we have discussions ongoing now about a global coordinating mechanism. We have all the right pieces in place for action. We're still missing the action. This is the WHO monitoring framework. A wonderful goal, 25% reduction in avoidable NCD mortality by 2025, 15 years, the baseline of 2010. This is readily achievable. In New Zealand, death rates have declined by 60% since the day I graduated from medical school. Clearly, cause and effect relationship. Member states of WHO have identified 9 target areas. We think that's too ambitious. I mean the Lancet the Lancet NCD Action Group, which I and Ruth are members of. We think the focus should be on tobacco use, on salt reduction, and the treatment of people at very high risk of cardiovascular disease through simple generic medication in primary health care. There are other targets that the member states of the WHO, in their infinite wisdom, have identified. We think, do the 3 first and then move on. I want to talk just about tobacco. I know that no one in this audience smokes. Well, it's not quite true. I've seen a few people smoking outside, but they were clearly in a great minority. It is the most readily preventable cause of NCD. If there's one thing we should do if we know a smoker, we should look that person in the eye and say, I advise you to stop. And surprisingly, people do stop with that sort of advice. But really, we have to be much more serious about tobacco. We have the advantage of the WHO Framework Convention on Tobacco Control, ratified by 167 countries, implemented so far by a minority. The treaty is there for implementation. There's much more to be done. The WHO target for tobacco control is a 30% reduction in tobacco use by 2025. We think that is grossly insufficient. New Zealand, I'm pleased to say, is leading the way. Our government is aiming for a tobacco-free country by 2025. And we're going to do that. We know exactly how to do that. The tools are there. It's tobacco taxation. It's smoke-free places. Now, following Australia's lead, it's plain packaging, changing the rules, upsetting the industry enormously. It's a good sign. So New Zealand is going to be tobacco-free by 2025, and that doesn't mean we're not banning it. People are beginning, of course, some people want to ban tobacco. That's not a position I support at this point in time. And we mean a very low prevalence, no new smokers, and a gradually diminishing number of middle-aged and older smokers. By 2025, we should be down to a prevalence of 5%. At the moment in New Zealand, 2 to 3% of doctors smoke. When I was a medical student, not all that long ago, 50% of doctors smoked. We smoked in hospitals. I smoked. We just did it. We didn't think about it. Now doctors smoke very small amounts. So we're aiming to be tobacco-free in New Zealand by 2025, government commitment. It's come from the people of New Zealand. They support us. The Lancet Group has a longer-term ambition for the world. Why don't we aim to be tobacco-free as a world by 2040? This is possible. We can do it. Of course, the big challenges are going to be China, interesting progress at the present time, Russia, Indonesia, perhaps India, but it can be done. I can't resist this slide. It's a bit out of left field, as you might say. We've heard a lot about working with the industry. This paper comes by Rob Moody from Australia. It comes from the last Lancet series on NCDs, published in February of this year. Profits and Pandemics. The global NCD pandemic, the 35 million deaths, is driven largely by changing risk factor levels based on aging populations and growing populations, but the risk factors are driven by industry, are driven by multinationals. The tobacco industry, of course, no longer welcome in New Zealand, but very welcome in many other parts of the world. Wonderful target of non-smoking women in many parts of the world. The food and drinks industry is responsible for much of the NCD epidemic. The question is, how do we manage the industry? And this paper suggests that it's a lost cause. This paper suggests that there's no evidence that public-private partnerships around food and beverage industries that it will work. And we think that regulation is the way to deal with the industry. Perhaps initially around salt reduction, for example, Ruth might speak more about this, an agreement on what the industries will do to reduce the salt intake of prepared food. That's where most of our salt comes from. And then followed up with the threat of regulation if independent monitoring of agreed targets isn't showing progress. We think industry has had enough time to demonstrate their social responsibility about reducing the high salt, fat and sugar content of their food. Some progress has been made, not nearly enough. We need strong government leadership there. And the question is, when we have downsizing states, centre-right governments, where's that leadership going to come from? The connections between the government and industry are very close. The pressure for that change is going to come from you, from us. Accountability for the promises that have been made, the commitments have been made at the UN high-level meeting is extremely important. Richard has already talked about monitoring, review, and leadership. And we want the monitoring of NCDs to follow the example that Richard has identified and set in place for women and children's health. We would like to move away from mutual accountability, I pat you on the back if you agree that I've done a good job, to an independent accountability system for NCDs, which in some countries could well be linked with the accountability system for women's and children's health, and for the accountability system, for example, for HIV/AIDS. We need to be thinking about this. WHO is not thinking about this at this stage. We've heard about the post-development agenda. There are two strands of work. One is the high-level panel, which met earlier in March in Bali, some disappointment expressed about the communique. Anders is very reassuring. The high-level dialogue on health that Anders and Joy Fumami led in Botswana, a very, very encouraging report indeed. Wonderful to see. The other process is set in place by the Rio +20 mechanism, with an open working group which has just been established. Somehow these two groups have to come together. And we would like, the NCD community would like, health and well-being to be at the center of human development, which we have in blue. Around the outside are the other 10 thematic areas that are being discussed under the UN Development Group, from education, energy, conflict, disaster, environmental sustainability, growth and employment, and so forth, water, conflict and disaster. We see that those other 10 thematic areas constitute what we understand to be sustainable human development. We think the unifying theme is health and well-being. And within the health and well-being nexus, we think NCDs are critical because they are relevant to old people, adults, young people, children. Maternal and child health directly related to NCDs. So we are beginning to see that NCDs might be the unifying health component of the Sustainable Development Agenda. And so in the middle we have the health and well-being goal, maximising healthy life expectancy, as Anders talked about, and came out strongly from the Botswana high-level dialogue on health, with NCDs as one important target area. Because of the 2030 timeframe, we're talking about a 30% reduction in avoidable mortality from NCDs. MDGs 4, 5 and 6, of course very important. Major risk factors, including tobacco use, as being another important target area. We're beginning to think about universal health coverage as an instrumental area, not as an ultimate goal in itself, but something we need to work on to achieve the MDGs 4, 5 and 6, to achieve the reductions in NCD mortality, and to achieve the feasible reductions in the major risk factors. And of course, there are many cross-cutting themes that we're supporting: life cycle approach, country ownership, universality of the SDG process, a rights-based process, and of course a lot on accountability. So this, for the NCD community, which has for so long felt excluded from the global development agenda, is a very exciting prospect. The thought that NCDs would take their place in global development alongside the unfinished MDG agenda, and perhaps other issues as well, is extremely encouraging. So in conclusion, and I wanted to say, emphasize it is possible to make very rapid impacts on NCD death rates. If smoke-free environments are introduced, it will have an impact on hospital admission rates within 3 months. These are not long-term lag times. These are very short intervention periods. And the interventions available are cheap and cost-effective, cost-saving. Perhaps it costs 10 cents per person per year to do effective tobacco control. Incredibly cheap, incredibly effective. Accountability is essential. We think that NCDs will be central to the post-2015 development area. And civil society, represented here by NCD-free organisation, of course there are many, many other civil society groups, have a critical role in shaping the post-2015 development agenda and ensuring that NCD takes their rightful place alongside the MDG unfinished agenda in that 2015 forward agenda. Thank you.
Well done, Robert. That was great. And we're going to have a panel discussion now. And let me invite our two panelists, Ruth Bonita, also from New Zealand, and Aaron Nanda, who you heard this morning. Welcome, Ruth, and to Aaron.
I do love that music. It comes very, very similar to Sailing the Seas Depends on the Helmsman, which was a revolutionary song sung
In New Zealand?
In China during the Cultural Revolution. But since you're our helmsman, we're feeling quite comfortable.
Right, well, as you can see, very pleased indeed to have Ruth here with us today. In fact, it was many years ago when I knew very little, in fact, nothing substantial at all about non-communicable diseases, and I saw Ruth deliver the most stunning lecture about NCDs and stroke, and she really put me on track for thinking about NCDs as a global health issue. And what I'd like to do is invite Ruth to make a few opening remarks, and then Aaron too, before we get into a panel discussion. Ruth.
Well, thank you very much, Richard. Yes, I guess I did start with stroke as my passion, and it very quickly moved into prevention and public health. It became very clear, very obvious, that you can't treat the world out of the stroke problem. You can prevent it. And I think that one of the things that Robert didn't really put a great deal of emphasis on was how you would do that. And there's an extremely cost-effective measure of doing it, and there's a very, very expensive one where the money goes down a black hole. And I'm talking about the difference between a salt reduction population approach right across the whole population, a small amount of sodium reduction for everyone, which will decrease population blood pressure levels. Crucial, because salt explains about 1 in 3 of all new cases of hypertension. The other approach, which I would say is exporting failure, is what we in our wealthy countries are doing to the poorer countries, and I see it everywhere. That is trying to tell people that you treat blood pressure. You cannot treat a third of the world's population. There are 700 million people with raised blood pressure, and how do you find them? You can't just go out and screen them for them, but you can identify them through primary health care. And so here's a nice tie-up between strengthened health systems, putting more emphasis in primary health care so that everybody who comes through the door gets their blood pressure taken, but not treated on that alone, but on the constellation of other risk factors. It'll have a huge impact, and very cheaply. Much cheaper, multi-drugs, generic. We've got to fight to ensure that generic drugs stay available.
Very good. Thank you very much indeed, Ruth. Let's give her a round of applause for those remarks. Aaron.
I'd just like to say that in the morning presentation there was a slide, and I hope you will get all the slides, which very clearly showed the economic burden of chronic disease. In fact, I will give some numbers just to illustrate what you just said. There are 169 billion annually spent in the EU on healthcare, accounting for 62% of the costs for cardiovascular diseases. For alcohol-related harm, there's 125 billion annually in the EU, equivalent to 1.3% of GDP. Obesity-related illnesses, over 1% GDP in the US, and between 1 to 3% of health expenditure in most countries. Cancer, 6.5% of all healthcare expenditure in Europe. Road traffic injuries, up to 2% of GDPs in middle and high-income countries. So the economic burden of chronic disease is without doubt. And I think in the end, these are the numbers that will make governments move, because money counts. The argument about mortality, the argument about health, well-being, this has been going on for years and has not made people move. I'd like to end by saying one other point, because which brought up the issue of the industry. I've had a long-standing view that we are today with the alcohol industry, well, actually for the 10, 15 years now, as we were with the tobacco industry in the 60s and 70s. And I really do believe that we are deceiving ourselves into thinking that somehow or the other, those people are not working together. Now there's proof. There was a study, which unfortunately I can't find the reference to, but it was in the BMJ, I'm nearly sure, that said, and it proved that these industries were working together, they were taking common policies, they were actually buying each other out, they were merging, and it is absolutely amazing. But when you look at the outcome, look at the outcome from your point of view. When I was young and I started to smoke, menthol cigarettes were the in thing. It was cool. Not cool as you call it today, but cool in the sense that it was good for your throat. Today, what do you have? Alka Pops. What are Alka Pops? They are cigarettes, type of cigarettes, bottled, marketed with nice colors, aimed at women, aimed at the young. Single cigarettes in my time, a single shot of alcohol in your time. You see how they work together and we don't.
Okay, now my job here is to challenge. And I want to pick up on some of the points that have been made in the last few minutes and just say, are we really right in what we say? A decade ago, I sat in an embassy building in an African country in a meeting with a representative of a donor government in Europe. It wasn't Sweden. And this individual, we were talking about what could be done for the people of Africa who are living with HIV. And so, what about the notion of providing access to antiretrovirals to people living with HIV? Nonsense, he said. A ridiculous idea. We can't possibly do it. Far too expensive. Absolutely unsustainable. Can't get the drugs to people. It won't work. What we've got to do is to say, let a generation die. Seriously? He said that. He was a senior advisor to WHO. Let a generation die and move on to prevention for the next generation. So, Ruth, when you say we can't treat all these people living with hypertension, and on April the 7th, it's World Health Day, and World Health Day is going to be on hypertension, is the message to the world on World Health Day, no, we're not going to treat you. You've had it. Die of your strokes, die of your heart disease, and we're going to move on to the next generation. And those are the people we're going to prioritize.
That's not what she said.
That's not what I said. But I'd also say that we are buying into a very strange concept. We're buying into a myth. I'd say there's something called the hypertension myth. Because the reality is there's some magical marker being used of 140/90, and anything above that, the guidelines, the clinical guidelines in Vietnam, in Malaysia, in all the countries that is really struggling is treat, find and treat. In America, they used to say find and shoot, but I mean, you know, anything over 140. The fact of the matter is that there are 10 times the number of people who have high blood pressure alone who aren't at risk. You'll never be able to get down their levels below that. You don't need necessarily to treat someone with that level. You need to look at the combination of risk factors. So as the smokers drop down, you know, at the moment you really need to treat people who are smoking and have hypertension and have raised blood pressure and who are obese. They're the problem group. And they're where you'll have the biggest bang. That's where you'll get the biggest number of events. So, Robert, you would agree with this approach?
Of course I agree with you, Ruth. I've had 45 years of agreeing with Ruth. The most pleasurable part of my experience. The other point about an arbitrary cut point of 140 is that the relationship between increasing levels of blood pressure and risk of death is continuous. Continuous relationship. There's no magical cut point at which suddenly you become at risk of a hypertension death and below that you're not. So half of the deaths associated with raised blood pressure occur under the 140 cut point. We need to adopt a population-wide approach to preventing all major risk factors, as we've done with tobacco.
And as we already know that all of the billions that have been spent in that direction would explain at the most 10% of the decline, not the huge promises that we're told about. And so, you know, and also people need to ask the questions, what's the knowledge? What's the knowledge based on? That definition is based on an ideal. None of us in this room have that level of 115. Everybody's risk is high, rate starts to go up after that. So to have a very, very low level that we're aiming for, and then to give this huge World Day attention, people are going to be thinking the old way. They're not going to be thinking of the new way of approaching treatment.
And also,
and that's the fear.
I'm not interrupting,
no,
Richard, I just had a thought. If we have a hypertension day, an obesity day, a cancer day, a breast cancer day, we're losing an integrated approach to the four major...
Well, I just want to pick you up. Exactly. That's the problem with your NCD movement. That's the big trouble, that you've got your political declaration too soon. You've got your political declaration, fantastic, but the entire NCD community is indeed that. It is the cancer community, the cardiovascular community, this community, that community, and you know as well as I do that when you sit in a room with all these wonderful people, they disagree about what the priorities should be. There's no unified answer, and they're all taking money from industry anyway.
That they're all totally corrupt.
So we've got a problem here, haven't we?
We have a
Seriously.
problem, but we have a huge opportunity. And the UN High-Level Political Declaration 2011 is the opportunity to to make the NCD movement cohesive. And we have a lot of work to do. And the last thing we want to see in low and middle income countries is they're learning the wrong lessons from what we have done in high income countries. We have an alliance, I know you're going to question this, the NCD Alliance, which is attempting at the global level to bring the four main diseases together, the hearts, the strokes, the diabetes, the cancers, and so forth. And that's a start. It's not working very well, but there is actually it's
That's
working.
an understatement.
Yeah, okay. but it's a slow progress. And I don't think the declaration came too soon. I don't think we have yet mobilized the NCD community to take advantage of the political declaration on NCDs, as the HIV/AIDS community did so brilliantly.
I want to just bring in Aaron here. Your observations, sitting in a regional office in Copenhagen from WHO. WHO deserves enormous credit for bringing a global consensus around the political declaration, but the challenge is implementation. Next steps, Aaron.
Okay, first just to say that I agree with what all of you said, purely because you're talking of primary and secondary prevention. And I think the point you were making was cost effectiveness, and I gave my numbers to show that in fact prevention costs very little, and it costs society as a whole hell of a lot from the disease. So just to close that particular discussion. On the issue of what we try to do with NCDs, I fully agree that in fact what we are seeing is that the MDG agenda was concentrated with very narrow eyes on 3 or 4 diseases. We were a bit worried when NCDs were left out, but we were not, how can I put it, powerful enough, or health was not powerful enough. It was driven from a different force. When the NCD community, or if you want to use that word nowadays, because when you set up one set of communities, then there is another group that comes up, and I think this NCD community is looking at some of the NCD diseases, and in a sense that worries us, because NCDs are much wider than just 4 or 5 diseases. But I'm quite happy to start somewhere to show some progress, and I have no difficulty with that. The best buys approach that people are talking about is, I think, a good way to start to move forward. But we mustn't forget the others. We mustn't forget suicides, especially in a time of austerity. We mustn't forget accidents, because they are actually quite huge. So I really do think that the progress that is being made is a good one. I love the chart that Richard had with health and well-being in the middle. It more or less exemplifies exactly what we have in Health 2020. That's what we've tried to do.
The fragmentation, Ruth, it's a real challenge.
The fragmentation. Well, I challenge you on that one. We do have a goal. We've got a 25 by 25 goal, right? And everybody's agreed to that. That's been accepted by all member states. The question they now have to face is how are we going to reach it? And what the Lancet has very nicely done over the last 10 years is built up that evidence and a series of 4 or 5 really scholarly sets of pieces, research, bringing all the evidence together. And it's really extraordinary. I mean, it's quite right. Some things are much harder to do something about. But there are 3 simple interventions that will have a huge impact. We're talking about millions of lives saved every year. 36 million lives in 23 high-burden countries could be prevented over a space of 10 years. Deaths.
Yeah, not lives presented.
Well,
that's the family planning bit of the conference.
Well, we've got this problem. We're not really preventing deaths. We are averting the death. So, you know, when you think about those numbers, they are huge. And you have to go back to your point about the economic connection. Poverty is certainly a cause of NCDs. The people are exposed at greater higher risk. NCDs cause poverty. Household income goes down as they spend more on unhealthy commodities.
I can see my friend Nisha there in the shadows. Come on in, Nisha. Come on, bring us the Twitter discussion.
Okay. Firstly, can I make a personal comment? It has nothing to do with Twitter. Just simply as an observer of all this, and that is that nobody outside this room has the faintest idea what an NCD is.
Yes, very true.
Okay.
Well, they do know what KFC is.
They do indeed.
Yes.
And you know what? NCD free, that little logo you saw on Robert's last slide, they are working on it. They're doing a marketing campaign. And we have to take the middle ground. We have to get a brand. I mean, HIV.
Well, that's exactly
you know what,
it.
What do you know? HIV, what's its long-term statement? Human-acquired virus, da-da-da. No one says that. They say HIV. We don't want to use the word non-communicable because, A, we can't say it, and it's a mouthful, and it's not a very nice word. It's something we're defined by what we're not. Forget it. Let's go for branding NCDs, and if you don't know what it is, ask someone, as people do all the time. I think we have to just say NCDs are like the HIV of the past.
And you have to say it over and over and over again, because
That's
people
right.
outside this room do not know what they are.
But they
Enough of that.
They do know what a heart disease is.
Exactly. And they know what strokes are. You know, they know, etc. So terminology plays a part of this. A couple of questions from Twitter. One for Professor Beaglehole, saying, are you serious that the Lancet NCD Action Group doesn't want to target on alcohol? And the other one is, and that was from IOGT International, another one from Jenny Wickford via Facebook, which says the 4th leading risk factor for NCDs is physical inactivity, and was mentioned in a recent article in The Lancet, suggesting it's now a pandemic. Why is no one mentioning it today? So I throw that into your laps.
Great questions. Thank you. So, Robert, why aren't you talking about physical activity?
I'm talking about 3 interventions which will help us achieve the global target. Once we've got these interventions in place and are making progress and have experience, of course we expand the agenda. Alcohol is very important, and the interventions are very cost-effective and work, has been described in The Lancet. And of course countries, as appropriate, should move on that. But let's do the simple, effective, and high-impact things first. Physical activity, I think the estimates in the global burden of disease I would take perhaps with a little grain of salt. No.
I can't believe you said that.
but because...
They were peer-reviewed. They must be true, mustn't they?
Yeah, of course. Physical activity is hugely important. It's very difficult to measure and very difficult to assess the relationships between some of the component NCDs and physical activity. I'm absolutely committed to physical activity in my own personal life, and I think we should be doing more. And earlier we heard a discussion about bike lanes and public transport, and so it is very important. And we do have there is a target, but it's not for me the immediate priority.
Ruth, this prioritization, you talked about these 3 interventions, but things are being left out that could contribute to 25 by 25, this goal, this global goal.
Look, there are many, many things that have been left out that could contribute. The question is, what are these interventions actually going to achieve, apart from looking good? I mean, all of the resources in country X, country M actually, I won't say which one it is, are poured into nutrition programs. Dozens and dozens of pamphlets and papers and posters and children out doing physical activity, etc. But they're ignoring the fact that they're being fed food high in sugar, high in fat and high in salt. And in fact, all of the pamphlets have been written by the very food industry. Now, there's no question of doubt that there are cost-effective interventions for alcohol, for diet-related things, for physical inactivity, and they come next. But there isn't one single paper yet that has been published or even shows how many events, deaths, would you avert with that particular intervention. How many deaths would you avert by getting obesity levels down? We don't know. The work has not yet been done. I'm sure it could be done, and I'm sure it will be done very shortly. But going back to Robert's point, start with what's simple and start with what we know.
Okay. But haven't we devised an agenda for NCDs that is about thinking about development in the way we've been thinking about development for the Millennium Development Goals? And isn't that just wrong? Because if we think about where we're going to be after 2015 and thinking about sustainability, and we've already been introduced to the notion of well-being, all this focus on death misses out the other big area, which was raised in one of the questions earlier today, disability. And what we know from studying disability is mental health is top of the list. Why are we not talking about mental health when we talk about NCDs?
What's the intervention?
So is that the only way we judge what because there
look, we have 20
the causes of mental ill health, as Aaron just said, the financial crisis and the austerity measures, we're seeing suicides going up in Greece at the moment. So it's not just giving a drug to somebody because they have depression. It's actually thinking of these broader determinants of well-being, mental health. Come back to René's talk earlier. If we brought in these broader issues, doesn't that help us, give us broader interventions, social interventions, political, economic interventions, which would actually help the overall movement around NCDs?
You're absolutely right, Richard, and that's why we have health and well-being in the centre.
Right.
The issue about mental, and there are close connections between mental health and NCDs. I mean, if you get depressed, you have a greater risk of heart disease, and vice versa. So the United Nations, in their infinite wisdom, concentrated on 4 NCDs. There is mention in the political declaration of mental health, and I think it's a challenge for us to bring the 2 strands together, the health and the well-being, the deaths and the disabilities. The other thing that we have to do, which you were alluding to, I think, earlier, Richard, was the connection between infectious diseases and HIV/AIDS. We know that if you now have HIV/AIDS, particularly in countries like Sweden, New Zealand, you have a chronic disease. You have it for 10, 20, 30 years. You are more likely to die of an NCD, of a heart attack or diabetes complication, than of HIV. The connections between the infectious disease agenda and the NCD agenda and the mental health agenda have to be brought together. But at the moment, the global target for NCDs relates only to the 4 main ones. But we, of course, need to work together, as we do with maternal and child health, as we do with adolescent health.
Right, so Ruth, Aaron.
Yes, and I'd like to also add that people who are depressed, who have mental health conditions, also have higher smoking rates, higher alcoholism, higher, you name it. I mean, it would do a lot of good to their health to reduce those rates across the board. So it's as René says, we must make sure that the marginalised groups are not left out. In New Zealand, for example, the government started out, and it was a wonderful advocacy tool, started out by getting all prisoners banning smoking in prisons.
Right.
And now that was an example, and then they're saying, wow, that was to protect the workers as well as the prisoners. And now they're saying in mental institutions and people, we need to help, we need to really give them assistance in cessation. And so a lot of work goes on to, and that in alone will make people...
A big difference.
So there is a big crossover.
So we agree there. Aaron?
As far as suicides and austerity is concerned, I fully agree with you, Richard. I mean, to me, we have to help these countries, and we have to do something about it. We are doing our best. It happened in the Balkans War. There also, as you know, suicide started to climb. Mental health was a huge problem. It is possible to do something. It's not easy. It's one of the more difficult jobs, but it can be done. In my time, when I was in England, mental health was one of the Cinderella services,
Yes.
along with the elderly. So we are moving on. I don't want, in any case, in fact, when Chris Murray did his first global burden of disease when he was in WHO, it was for the reason that mental health never figured. And as we all suspected, it was high up on the dallies. Now we've gone another way and it's somewhere else, but that's another matter.
Okay, I want to go from this slightly global discussion to countries now and think about what really needs to be done in a country in terms of translating the evidence into policy, into action. So I'm going to start actually with Ruth here, because I know, Ruth, when you were at WHO yourself, this was your particular concern. What do we do in countries to build the technical assistance to make progress? Give us your thoughts about, if you were in a country now, where would you begin in terms of addressing the NCD epidemic that's gripping these countries?
Well, the good news is that, well, the bad news is, let me tell you this first of all, some countries basically have no capacity for NCD in their ministries of health. Right. They might have one person allocated, or somebody's doing something on physical activity or nutrition in schools or whatever. And what has come along has been some additional funding, largely from Bloomberg in many countries, which has put capacity in, helped train people, put them into ministries of health, slightly outside, unfortunately, but it's starting to build the capacity. I put all my hopes in countries around regulation and legislation around tobacco, but it also, what also has been very helpful in these countries is to build capacity through helping countries develop surveillance systems to measure these risk factors, to watch the trends. These are risk factors. If the trends are going up, you don't need to measure the diseases. You could, if blood pressure levels in the population are going up, stroke will go up. If you see obesity levels going up, you know diabetes will go up. So there's some bit of warning time there. So countries want their own information, and they're getting it, and they're not using it terribly well necessarily, would you say? But there's a lot of help from the regional offices. I'm also a great fan of WHO to put that technical work out there, to build the capacity, to run the workshops, get people trained. So what's missing, however, I'd say, the agenda has changed. It's changed so fast because we are now into a much broader area, as you talk. People in the ministries need to know about trade. They need to know if they're signing up on a trade agreement, how is that going to impact on health? They need to know how you would put in place laws and regulations around foodstuffs, for example. And as for building awareness, mass media campaigns, I mean, there are mass media ways of doing that. We can make a lot of change now. So we need to get these, we need really to build new mechanisms and structures like national commissions on NCDs. I don't know if that's being discussed by WHO, but if you don't have a group who's going to be accountable.
But one of the lessons we have from the successful global health movements like the AIDS movement is that it was civil society that was the critical instrument to accelerate political progress. And without civil society demanding governments to take more serious action, then the likelihood is we would not be in the more advanced place we are with AIDS if they hadn't done that. So where's the civil society movement for NCDs in countries? Because honestly, it's mostly absent, isn't it?
It is mostly absent, and when it is there, it is very disease specific, often advocating for expensive treatments for particular conditions. I think the critical thing, even before civil society engagement, is data. The country M that Ruth and I were in recently, they did their first national health survey about risk factors, building on Ruth's invention, the stepwise approach to surveillance.
Right.
This data was taken to the Prime Minister. He said, I don't believe it. It's impossible. How can we have, 5 million obese people, 10 million hypertensive in this country? There was no awareness at the political level of the extent of the emerging problem. I think there's a critical gap in many countries. We had this discussion last night about Nigeria, about basic data on risk factor distributions in the country. That is the underpinning of policy. That is the information that an active and a progressive civil society group can advocate on the basis of.
Yeah.
So I'd start with information.
But what you've identified there, Robert, is probably one of the most unfashionable areas in global health, which is strengthening health information systems, civil registration, vital statistics. I'm with you 100% on the importance of civil registration and vital statistics, but over the last decade, 2 decades, we've made almost zero progress. Again, lots of advocacy, lots of promises, lots of commitments, nothing much happened in countries. Why have we failed to be able to measure the problem in countries?
We are making progress.
We are?
In the Pacific, where we've been working most recently, coming from Alan Lopez and his Burden of Disease group at the University of Queensland, they have developed very nice tools for civil registration vital statistics based on verbal autopsies. I mean, it's not ideal data, but it's starting. It's coming. And I think the Global Burden of Disease study, which I understand was published in The Lancet recently, is a wonderful example illustrating the need for basic data.
Yeah, but the problem with that, great, it was great, but the problem with that is it's not actually building a health information system. In fact, you could say it undermines the need for building a health information system because they're taking data from the country, doing wonderful analyses in Seattle, and then not actually helping build those systems you actually need on the ground.
Well, that is disgraceful.
Don't tell Chris I said that.
And you are facilitating that.
I know. So I feel, why do you think I'm getting anxious about it? Because I'm feeling a little guilty that we as a global community are not doing enough to invest in those systems.
Well, absolutely right. And the STEPS system that Ruth invented has been applied in 100 countries. The data are not processed and not available in a timely manner. So there are issues about not only having the data, but making sure it influences policy. And we've got to be much better at that. And the data has to be owned by the countries.
Nisha.
There are loads of good questions coming on Twitter, Facebook, on mental health, the economic effects of NCDs, health promotion in general. But there's this particular one that I really must throw at you guys, and that is, it's from Ida Niskanen, I think is how you say it. The panel's opinion on taxation on unhealthy foods. Thought and all that.
Okay.
And there's a part B, which is, and what about meat consumption? And
about what?
Meat consumption.
Well, have less of it.
Or something.
Or more of it, or do something about it.
Well,
okay, taxation. Come on, you're going to tax
I'm going to...
unhealthy drinks?
Absolutely.
Food?
Sugar-sweetened...
Big Mac?
Sugar-sweetened beverages and immediate substantial taxation across the board. Sugar-sweetened beverages for important cause of obesity in children.
But you know, Robert, you know what people say when they say that? You say you're taxing the poor.
Yes.
You're taxing the poor because it's the people who live in poverty who have those diseases. So what you're doing is you're deepening inequality, and Renee is going to be angry with you because you're not closing the gap.
Not at all. We've done exactly this on tobacco, and we found that tobacco taxation increases are the most powerful tobacco control tool we have, and we know that poor people are the most responsive to tax increases for tobacco. They want to stop. 2/3 of all smokers want to stop. So if we're going to penalise the poor through increased taxation, the idea is not to subsidise sugar-sweetened drinks and give it to poor people for free. because that's what they might want. We've got to make sure that the welfare system, the growth in the employment system supports people. So we've got to keep the broader agenda in mind as we do the simple things. Taxation, fiscal measures are the way to change people's behaviour, whether that's sugar or fat or fruit and vegetables
Aaron,
and the other way.
is the Director General of WHO for taxing junk foods and junk beverages? Yes or no?
Don't ask me a question like that. Even though I'm close to retirement.
What is WHO broadly?
Even though I'm close to retirement, I don't want to be fired at the moment.
But
I can't put words in my Director General's mouth, but I would say this.
Yeah, go on.
I do believe that what the industry is doing in the food industry is clearly for economic reasons. They use salt, as we all know, because it's a cheaper preservative than anything else. We have to work with them. I don't think they will do it on their own. I have memories of the time when I tried. So I think that we have to, and in the end it's probably a combination of a lot of things that will allow them to move. The Director General in US raised the C word first time with tobacco in the mid-60s. Here we are now, 40, 50 years later, and we are seeing some progress. Let's hope we are faster with food.
Very good.
It's interesting that the very multinational corporations that are producing these unhealthy commodities are the very ones who don't pay any taxes anyway. Right. They've got $21 trillion hidden away in the tax havens in Netherlands and little islands strung out in Cyprus.
She had a question
$21 trillion of unpaid taxes. It's so much money, and this is not the hands of the 1%. This is the hands of the 0.01%. The very, very super filthy rich people who then turn around to what can they do with their money? They actually bail out the governments and they help. So we've got a very strange situation here. They fight against taxes on unhealthy commodities. They want to keep it cheap.
Yeah, we should try something. We have just, in Denmark, as you know, there was the tax on
yes, right.
And that's been withdrawn, as you also know. And I'm going to try to urge the Nordic group to actually do a study to see, because we've tried it, did it work, didn't it work? I think we need some more evidence, as Richard pointed out. We need evidence on a number of things.
Okay, very good. Are we for meat or are we against it?
We're for eating a small amount of high quality New Zealand lamb. Because New Zealand's economy depends on that, and if you
just like China's depends on fossil fuels.
And if you also drink low-fat New Zealand milk, we will be eternally grateful. And the products of New Zealand's agriculture are produced in a natural environment, because the weather is so wonderfully balmy. The cows and the sheep, they wander.
All right. I know you want to go home. I know. I understand. Ruth, thinking about the relationship between agriculture and chronic diseases, non-communicable diseases, there is a serious intersection there, isn't there?
There is.
And we haven't fully addressed how we can bring in the agricultural community to the health community.
That's entirely correct. And this is where you see this, the nice aspect about this whole meeting has been to have climate linked with health and inequalities. If you think about alcohol production, we do that very well in New Zealand too, you know, very well.
Yes.
But we use huge amounts of water to do it. So there's the alcohol industry's using up water. It's moving into countries where their temperatures are starting to rise, and now they can grow grapes. And they're killing off food production to grow grapes. So there's one good example of the agribusiness. But the agribusiness whole industry is really about not making food for people, but to make food for markets and profits. And what we're witnessing is a rapid transition in the way in which we consume and access food throughout the world. So I think you cannot but involve agricultural, but it's not just agriculture, that's why we come back to the multi-sectoral approach.
And on that note, I think we should lead this discussion. Please give a big round of applause to Robert, to Ruth, and to Aaron. Well done. Well
Very
done.
good helmsman.
Well done. And now, ladies and gentlemen, you have a health break, but we don't specify what you're going to do in the next 30 minutes. But whatever you do, make sure it's healthy. And please come back at 5 o'clock for the final session. Thank you.